Today I'd like to talk to you about a few health myths that keep popping up in clinic, things that patients mention, recurrent themes that keep coming up, but I'd like to take a few minutes just to talk through a few of those and dispel some of those rumours. So a recurrent theme when people come into the clinic is they say things like, I don't want to take painkillers because it's only going to mask the pain, or I don't want to take painkillers because I don't want to do any damage to myself with it. This is a common theme that occurs. What I normally say in this situation is, firstly, painkillers are there for a reason. They were made for these situations. They were there to kind of calm down your pain with it. And the second one is, if I do take a bunch of painkillers and you hit me on the foot with a hammer, I'm still going to feel the fact that you've broken my foot. The painkillers are going to make it slightly more comfortable, but they're not going to stop me being able to feel that. The other thing where it gets a bit more complicated with this is painkillers can actually be a really useful part of the rehab journey as well, because if the pain is really poorly controlled, where it's world-ending pain is always there, meaning you can't do the exercises, you can't move as you would do normally, actually that lack of inactivity can mean that things get stiffer and things get more uncomfortable, and it can hinder your recovery. If you do have some painkillers to dampen it down, it means that you are able to get your foot in the door with moving, you are able to get your foot in the door with doing some exercise. Don't get me wrong, that doesn't mean that everyone needs to have painkillers, but they're there when they're needed. You need them when you need them, basically. So quite regularly we get people through the clinic who say that, well, you can't diagnose it if you haven't had any imaging, and that's also not true. The first thing that we do with any assessment is that we sit down and have a long chat about the history of the patient and the history of how this all came on, mostly because if you look through the research for the vast majority of medical conditions, the best diagnosis is that history taking, finding out the ins and outs of everything that's been going on and how this started in the first place. An example of this would be if you have pain over your Achilles tendon that correlates with increased load amounts of running, it's painful to press the tendon, it's painful to stretch the tendon, it's painful to challenge the tendon and work it, there's probably an issue with your Achilles tendon. So it's things like that, with getting that pattern recognition, that history taking to find out how this all started, because that will inform most of what's going on. Don't get me wrong, imaging has its place, scans have their place, and sometimes we do need to go deeper to find those things, but the majority of the time, just by doing a thorough assessment and taking your time with it, we can diagnose things from there very accurately. So a diagnosis of arthritis isn't automatically doom and gloom, circling the drain before you need a joint replacement as well. One thing that often isn't articulated clearly when people get a diagnosis of arthritis, particularly with like hips and knees and things like that, is once you get past a certain age, the majority of people do have some form of it as well, mild or moderate or severe in some cases. There are things that can mean that you're more prone to getting arthritis, so family history and genetics and things like that, lifestyle, activity, body composition and things like that as well. But at the same time, just because you have the arthritis doesn't mean there's nothing you can do about it, and doesn't mean you automatically need to have a joint replacement. In a lot of cases, with lifestyle changes and exercise, it can help get rid of or improve arthritic pain. And sometimes things get to a certain point where they've gotten really bad and they plateau, they don't get any worse. Sometimes things do get worse, and obviously people do have joint replacements. In some cases, the pain can kind of completely go away, or usually more often not improve. There are situations where people in their like 60s have said, oh, you've got arthritis in your knee, but then flash forward to their 80s, things aren't feeling too bad, and actually the arthritis stayed the same, it hasn't got worse from there. So it's not an automatic thing where you need a joint replacement if you have arthritis, and physiotherapy can very much help in calming down the symptoms, even if we're not changing the fact that the arthritis is there. So unfortunately, this is probably the more common one that I hear in clinic, where people say that they feel like they can't, they're too old to be doing exercise, but there's no age where exercise is no longer appropriate for you as well. You can benefit from exercise at any age, whether you're 9 or whether you're 90, but as we get a bit older, we need to tread a bit more carefully with it. When you're 19, 20 and things like that, you can jump into an exercise you've never done before and go hell for leather with it. However, as we get a bit older, we do need to tread a bit more carefully with this and ease into things. Things like resistance training and cardio exercise are really good at an older age, but you just need to ease into them more than going hell for leather with it, but it's perfectly safe. So I hope you found this video useful. If you do have any topics you would like me to address in this, feel free to email me and let me know, and I'm more than happy to kind of make a video on the topic. But if you do have any aches and pains, anything we can do to help, please let us know, and we'll see what we can do to get you back on the road to recovery. Take care.